This combination, azacitidine plus venetoclax, is now the reference treatment in AML in the elderly, that is patients considered unfit for intensive chemotherapy. In MDS, it's mainly currently tested in high-risk MDS, that is patients with a high or intermediate or very high revised IPSS and who have a high risk of progression to AML and poor survival due to major cytopenias. So far, azacitidine was the reference treatment, moderately improving survival to a median of 20 to 24 months, rather 20 months. And based on the results obtained in acute myeloid leukemia, which is of course very close to high-risk MDS, trials are ongoing with the combination of azacitidine and venetoclax in high-risk MDS. And early results suggest that the response rate is going to be improved over azacitidine alone, which only yields about 20% CR, and with Aza plus venetoclax, the CR rate could be about 45%. And perhaps more importantly, the median survival may be increased from about 20 months to 26, 27 months. It's still unclear. Now, the problem with azacitidine is that it worsens the cytopenias already observed with azacitidine. So the combination is more myelosuppressive, but whereas azacitidine yields responses generally after 3 or 4 or even 6 cycles, it appears that the combination will yield earlier responses, so that eventually the initial myelosuppression may be worse, but if the patient responds faster, then there will be no myelosuppression in the subsequent cycles, and eventually the overall duration of myelosuppression will be less. So that is at least what is observed in AML in the elderly. So we hope that patients the same will be reproduced in MDS, that there will be a survival advantage. Now, which patients will benefit most? Well, probably, of course, higher risk MDS. And in those patients, if the same is observed as in AML, patients with complex monosomal karyotype, etc., will probably benefit less. For example, patients mutated for TP53, etc., whereas patients with more favorable karyotype or simple abnormalities may benefit more. So that's what we hope. Also, this combination may be a good opportunity to rapidly reduce the blast count. So it may be interesting in patients who are candidates for transplant, because you reduce rapidly the blast count, and that allows you to perform allogeneic stem cell transplantation in those patients. And perhaps I would say finally, as in AML, now in AML, triplets are being tested. I mean, azacitidine plus venetoclax plus other drugs. We may quote a few of them: pevonidostat, magrolimab, sabatolimab, and we hope that in high-risk MDS the same may occur. That we may in the next few years indeed have combinations that further improve survival. It's a bit what I call the myeloma example, where in myeloma, with addition of drugs over the last 20 years, especially in first line and in second line, with the advent of new drugs, prognosis have improved, and myeloma has moved from a disease with a median survival of less than 3 years to almost a chronic disease now. So hopefully in MDS we may hopefully observe the same to some extent, knowing also that those patients are often older, and so not everyone will be able to receive those relatively intensive regimens. In particular, azacitidine plus venetoclax is, of course, potentially difficult to envisage in very old patients. I mean, older than 80, 85, etc. And we see those patients now. So we'll have to reduce the doses, but it should be promising. I mean, that's what we can hope, and therefore waiting for the clinical results of ongoing studies.